He is Managing Director, Senior Consultant and Interventional Cardiologist at Dr. Mathavan Scott Center, Madurai. He is a former Director of Interventional Cardiology at Velamal Medical College, Madurai. He did first coronary intervention in 2000 in South Tamil Nadu. So played a pivotal role in establishing the cardiac lab at Apollo Hospital, Madurai. He has conducted a research project with the distinguished cardiologist and Nobel laureate Dr. Bernard Lowe in Boston. His areas of interest are intravascular imaging in rotational atherectomy, which he used to address challenging his PCA cases. So now the stage is yours, sir.
Thank you. This is the Brownwald textbook of cardiology. This is the 5th edition, 1996 edition, which I read for my examinations. Dr. Brownwald is a master cardiologist and he is the editor-in-chief of Brownwald. He is also contributing editor to Harrison textbook of medicine. You all must have heard TIMI trials, TIMI 1, TIMI 2, TIMI 3 from thrombolysis onwards. And now we have TIMI 56. So such a great cardiologist. He has identified atrial fibrillation as the global epidemic. So such a statement comes from Dr. Brownwald means it's a lot to be taken. Because atrial fibrillation is not a benign condition. The stroke followed by atrial fibrillation and the stroke without atrial fibrillation, there's a lot of difference. The 1-year mortality due to the stroke because of the atrial fibrillation, non-valvular atrial fibrillation is around 50% compared to stroke due to some other reason. So it's not a simple thing because it is increased risk of death and very disabling condition, and it has a very poor outcomes in survivors, and we also have an increased risk of recurrent stroke. So it's very important and to note that the treatment of atrial fibrillation is not adequate, it is not well concentrated, and therapeutically only 10% are really getting the right dose of anticoagulant, that is traditional warfarin. We just go on treating atrial fibrillation as a condition which gives palpitation. It's a bad disease which leads to a remodeling of the atria and leads to atrial fibrillation, chronic atrial fibrillation. So it's not just the palpitation, it's not just, may not be the atrial fibrillation. The stroke is the most serious complication of the AF and it is more disabling. There is around 15-fold increase in the risk of stroke with non-valvular atrial fibrillation and also valvular atrial fibrillation. And besides this disabling stroke, it also can cause dementia, which is notified in age less than 75 years old people. So we know that it's very important to treat atrial fibrillation with anticoagulations. But before doing so, we have to identify some reversible causes of chronic atrial fibrillation, such as what is mentioned here: sleep apnea, hyperthyroidism, WPW, drug abuse, alcohol dehydration. Once we have decided to treat atrial fibrillation and we have ruled out all the secondary causes of atrial fibrillation, now what next? We have to know 3 important scores, that is CHART score, CHART vascular score and Hasbled score. The CHART score is this: you have a score, points for each disease. Congestive heart failure 1 mark, hypertension 1 mark, age more than 75, diabetes, prior stroke. Prior stroke has 2 marks. So first you should know about CHAT score, you should know about this. And if the CHAT score is more than 2, straight away you have to treat with anticoagulation. Suppose if the CHAT score is not 2, it's less than 2, 1, then you extend it by CHAT's vascular score, where we add last 3 1, VASC. V for vascular disease 1 mark, age 65 to 74. You remember in CHAT score it is above 75. Here we have given 1 mark for 65 to 75 years old, and for the female 1 mark. So you do CHAT score, you get 2 more points, treat the patient. If you get 1 point, extend the score to CHAT's vascular, and if it's 2 mark, then that patient has to be treated. And it's better to know about the Hasblit score. This just tells you about what Salomoni has mentioned, the bleeding tendency of the patient. It will be useful for the follow-up of the patient when you treat the patient. So CHAT score, CHAT vascular score, very important. What next? Next, we have to treat with warfarin. We all love and hate warfarin. We love warfarin because warfarin has been useful for more than 5-6 decades, and it has saved and saving a lot of mechanical valves. So it's a wonderful drug, but the problem is it's very painful to use the warfarin because of so many side effects. But you must also be thankful for the drug which has been around, which is still being used in the contemporary era. So treating with anticoagulation, especially with warfarin, is like this. You have to walk in a tight rope. If it exceeds, you have intracerebral bleeding. If it is less than the desired value, you don't get adequate efficacy. You may land up in stroke or land up in problems. So these are the problems. If you use warfarin, the PT-INR should be between 2 to 3 or 2 to 3.5. Suppose if you do not get the adequate PT-INR, there is a problem. If it is INR is 1.3, then there is a 7-fold increase in the risk of stroke. If it is 1.5, 3 times increase. If it is 1.7, nearly 2 times increase the risk of stroke. On the other hand, if the PT-INR goes high, 4, and you have a risk of bleeding. So that is a very difficult situation. So that is the handicap of warfarin or any acetocomerol agents. So the limitations are, number 1, very unpredictable response. You do not know. You will pseudo seen in your practice. PT-INR would be 2 in one lab. You will find 1.5 in another lab. That's a very highly unpredictable response. Unpredictable values from lab to lab. Narrow therapeutic index. You don't know. You may have added some food. You may have added some drugs. So the PT-INR changes. So narrow therapeutic index is a very bad thing. And you have to have routine monitoring and slow onset and slow offset. And you have to adjust very frequently. Patient has to visit to you. You have to ask so many questions. If it is a mitral patient, you have to look for the click. You ask some questions about bleeding and a lot of food interaction. You have very limited number of foods that is interacting, but remember there are many other foods which we do not know has got interaction with warfarin group of drugs, and drugs to drugs interaction. That's another thing. So some drugs, suppose you take carbamazepine, you stop it, immediately the INR goes high. And it also has got some resistance with the cytochrome C2, C9 and other genetic polymorphisms. So now you know that CHAT score is 2. You are considering anticoagulation. And this issue has been discussed way back 70 years ago by Chicago Medical Society Bulletin. newer anticoagulant? Can we look forward for a better anticoagulation? So now we have got good anticoagulants, of which three are very important, and I think most of you are using these three agents: apixaban, dabigatran, and rivaroxaban. The advantages is that it quickly achieves the maximum blood levels, and anticoagulant effects for administration. Absorption elimination is largely unaffected by food or other medications, but some drugs can interfere, which will come later. You can administer in a fixed the monitoring is not required. Sometimes it and receptor inhibition, short half, and equivalent effect diminishes quickly after discontinuation on contrary to the warfarin. And these are the pharmacological properties of the newer anticoagulation. Here the apixaban and the rivaroxaban acts on factor 10A. So dabigatran acts on factor 2, thrombin. The most important thing is you have to look at the renal clearance. That's the most important thing. Renal clearance is very important thing for the day-to-day management of these patients. Dabigatran has got 85% renal clearance, followed by rivaroxaban, then apixaban. And this also has got some inhibitors like cytochrome P, 3A4, and there is something called glycoprotein P. Anything which inhibits glycoprotein P has got some interaction with these newer anticoagulation, which is very, very important to note. And dosing is apixaban and rivaroxaban. Apixaban and dabigatran are twice daily, and rivaroxaban can be given one. I am the part of Rocket AF trial, which is we studied for AF, non-valve AF in the year 2000. So, few things you should know about these studies. These three studies are non-study trials which compared with warfarin. And some important things you should know, that you must know the renal functions and you must know the age. So based on these two things, we can adjust the medication. So basically all these trials were conducted patients above 30 ml creatinine clearance. So basically below 30 it is not to be given. There are some exceptions. That is the most important thing. The important point I want to emphasize here is you problems before initiating this table. This is one of the more so, dabigatran 150 BD is the best in preventing stroke and systemic embolization than dabigatran 110 mg and rivaroxaban. So dabigatran 150 BD, rivaroxaban, apixaban, then rivaroxaban. So that's a very important slide. It favors good compared to warfarin. But very interestingly, the same anticoagulants, 150 mg BD, if you bleeding, that is something very important. If you think a problem, the same dabigatran. So comparatively for renal, for the GI patients, apixaban is the better one because the least bleeding tendency. You have to divide basically between 30 ml and above, 15 to 30 ml, and less than 15 ml you can see apixaban is not recommended, whereas dabigatran is contraindicated. Please see the wordings. So it's very important slide. This is a very complex and confusing slide. You all to copy this particular slide, keep it in your clinic. When the patient comes, phone. When the patient comes, you should be able to do the GFR, and based on that, you can follow this flow chart. You can give apixaban, apixaban, dabigatran. Edoxaban we don't use. I don't think it has come. Last month it must have come. I don't know. But the important thing is edoxaban cannot be given the patient who has got creatinine clearance more than 90. More than 90, you are not supposed to give edoxaban. Anyway, it is not in the market yet. So these three are very important. So with these ideas, you can initiate and you can follow the patient up without any much of the problems. The next question is, does VKA, that is warfarin, to be dismissed from our wish list? No, because still for mechanical prosthetic valves, warfarin is a drug of choice. Of course, there are some studies are going on. David AF trial is one trial which they are trying to look at low dose mechanical valves, especially in mitral position, and the moderate severe, it is an anti-positive antibody syndrome. Yes, it is to be avoided. LV clot, I think still warfarin holds good. And the end-stage renal disease, of course, it is not indicated, but in hemodialysis patient, possibly you can use newer anticoagulations. It is not newer anticoagulations because this was introduced in 2012, so it is called direct anticoagulations. DUAX, not NOVAX, DUAX. Important thing, one thing I talked about glycoprotein P, which is present as a co-transporter, which brings back the absorbed material into the bloodstream. So some drugs like verapamil, diltiazem, amiodarone, these drugs, most of our prescription has these drugs also along with anticoagulation. When you use these drugs, you must be very careful in reducing the dose of dabigatran. Instead of 150, even 1. True for all the patients, even for all the drugs or apixaban. But apixaban is the least bleeding tendency drug. So there is some proposal for the hemodialysis patient. Obviously, for hemodialysis patient, you can give apixaban 2.5 mg BD, and during the dialysis, you can reduce the dose of heparin instead of standard dose. And for liver failure, mild liver failure, you can give you can give warfarin, you can give newer drugs. But if it is moderate, you have to be careful. Severe liver impairment, you should not give. I think with this I will stop. And you must also know the timing of the last oral anticoagulant intake before an elective intervention. Because most of us physicians get a reference from dentists and surgeons, what should we do? When should we stop the medication? Mostly 24 hours is enough. You divide the surgeries, whether it's a minor surgery, high surgery, moderate degree surgery or high risk surgery. If a minor surgery is just 24 hours is enough. And look at the creatinine clearance. If the normal renal function, minor surgery, just 1 day, 24 is enough. If you have added problems, you just make it 48 hours, depending on the drug, depending on the renal status. Or sometimes you have to go up to high risk surgery, you may have to even stop 3 days or 4 days. Because this is very important, this is again a very important slide, which you will come across in day-to-day practice. So I think with that I will stop it. And if time permits, what is the role of AF with ACS or PCI for anticoagulation. What they suggest is you give anticoagulation and patient you can add aspirin for 1 month. Why 1 month? Because the first month is the highest chance of, you have highest chance of thrombosis. So you can have anticoagulation plus clopidogrel for 1 year. After that, you can even stop the clopidogrel. Patient can go on with only anticoagulation. Thank you very much. I think I will conclude saying that antiplatelets won't work for AF. It's not benign condition. It's a very serious malignant condition. NOACs are definitely superior, but please consider renal function. Apixaban has got least bleeding. Dabigatran can cause GA bleed. In hemodialysis patient, low dose is preferred. Mild liver diseases, these drugs can be given. Warfarin, VKA, still has got a role. Thank you very much.
Thank you, sir. Your